like, I realize that Joe did this. I don't know. All right. Well, thank you for being patient with our tech. Apparently our internet thought it was Monday, and I'm guessing many of us can empathize with that. So I am delighted to have Michelle Meyer here to present to us about experiment aversion, a challenge for learning health systems. So Michelle is Associate Professor and Founding Chair of the Department of Bioethics and Decision Sciences at Geisinger College of Health Sciences. She is also Geisinger's Chief Bioethics Officer and the founding faculty co-director of Geisinger's Behavioral Insights team. Michelle earned her PhD in Religious Studies from University of Virginia and her JD from Harvard Law School, where she was an editor of the Law Review. She clerked for the U.S. Court of Appeals for the 11th Circuit and received postdoctoral training as a Greenwell Fellow here and also with the Petrie Flom Center at Harvard Law School. So please join me in welcoming Michelle Meyer.
Thank you so much. Can everyone hear me? Okay. Okay, great. Thanks so much for that introduction. It is wonderful to be back. I'm going to get right to it, given our technical issues. So I'm going to get into this talk by making a stark and sobering claim, which is not new and shouldn't be, unfortunately, very controversial. And that's that doctors don't know what they're doing. This is an essay from 2002. And this is written by an internist who said, you know, the vast majority of medical therapies have never been evaluated by systematic study and are used simply because doctors have always believed that they work. Now, to be fair to doctors, this is not just about them. None of us know what we're doing, actually. So here is a blog post by the then CEO of OkCupid, which for the younger folks is a dating app. And he admits, you know, OkCupid doesn't really know what it's doing. Neither does any other website. It's not like people have been building these things for very long, or you can go look up a blueprint or something. Most ideas are bad. Even good ideas can be better. Experiments are how you sort this all out. And so in response to this stark reality that none of us know what we're doing, in the business space emerged this idea a long time ago. This is from 1993, very long ago. Only some of us were alive then. Of the learning organization. And Garvin defined it as an organization skilled at creating, acquiring, and transferring knowledge and at modifying its behavior to reflect new knowledge and insights. And of course, in the healthcare space, the Institute of Medicine many years ago espoused the idea of a learning health system, one in which knowledge generation is so embedded into the core of the practice of medicine that it is a natural outgrowth and product of the healthcare delivery process and leads to continual improvement in care. Now, one critical tool in the learning health system toolkit is randomized evaluations. These are often called pragmatic randomized controlled trials or pragmatic RCTs. Social scientists who do them in other domains often call them field experiments. In industry, back to OkCupid, for example, they would call them A/B tests. I'm going to use as shorthand A/B tests most of the time during this talk. They're roughly the same thing. And so here are two examples of units that have been set up at NYU and Vanderbilt that are dedicated to running randomized evaluations. I should say Geisinger also has one that I'm the faculty co-director of. Penn also has one that focus on behavioral science informed interventions. Happy to talk about that in Q&A. And so what do these types of units test? Well, they either fall into a category where the things that are being compared, call them A and B, are either existing interventions, so they're like already approved if they needed any sort of approval rather. They're within a standard of care, they're in practice, but the comparative risks and benefits are unknown. So that's one category of things that can be tested. Another category are new interventions, but they're not experimental drugs or devices. No, they're things that are totally within the power of leadership to universally and unilaterally implement. We'll see some examples of those, but things like practices and policies around a hospital, for example, that no one would frankly ever be consulted about, but which may or may work better or worse than an alternative. Okay. The other thing to mention about all of those is that it is virtually never the case that consent is obtained for these types of A/B tests, whether of patients or providers. This is largely going to be an empirical talk. And so I don't have time in this talk to give a full normative defense of the idea that it can be ethical to conduct some A/B tests without consent. So I'm going to cheat and point to illustrious colleagues in the field who have already made this argument, some as long ago as 1999. Others, I suspect you will recognize their names particularly. Okay. So, despite all of this, there's agreement, at least among some ethicists, that some pragmatic trials, even non-consensual, can be ethical, and that they're very valuable in advancing aspirations towards a learning health system. But there's been a lot of controversy about some A/B tests when they have happened to kind of bubble up outside of the ivory tower into the public consciousness and media. So I actually, ironically, didn't enter this line of work, which I've been working on since roughly 2015 or so, in one way or another. I actually entered it through the industry A/B testing space, and in particular through the Facebook so-called mood contagion experiment. I don't have time. It would take the entire hour to unpack that, and we would go down multiple rabbit holes. But I will just assert that one way of looking at what happened there is that the A and the B conditions that were being compared were both within a standard of care. That is, they were both within the exposure that the average, a typical Facebook user would have experienced within some reasonable period of time. And yet there was quite a bit of outrage, quite. This is just one tiny example of a Wall Street Journal coverage. Now, Christian Rudder, I guess, was feeling left out. And so a month later, he wrote that blog post announcing, we experiment on human beings too. And he was rewarded with a New York Times expose of their A/B tests. A little bit closer to home, arguably the support trial meets some of these similar patterns. And that, of course, was very controversial and really divided the research ethics community. I will say that did involve consent, although part of the criticism was that the consent was inadequate. There were also the COMPARE and iFirst trials. These were large pragmatic trials of medical and surgical resident duty hours, comparing two different policies, both of which had been sort of official policy in the recent past and people had different opinions about which was better, but they'd never been compared in any systematic way to one another. And that, of course, received some pushback. And most recently, in Norway during COVID, they decided to reopen schools at some point for grades 1 to 4, but for grades 5 to 10, they decided not to reopen school for those grades. And this scientist, I'm sure working with many others, just put together a protocol to randomly evaluate reopening grades 5 to 10. And it got as far as a trial registration. You can see the number there. And then unfortunately, he announced on Twitter or X, whatever it was, in 2020, that the Minister of Health had sort of pulled this. And he said, the Minister of Health announced he thought it was a good idea, but he thought it would be too difficult to get popular support for it. All of these examples, I will acknowledge, are complicated, they're nuanced, and the people who object to them, including my colleagues in the ethics space, have, generally speaking, nuanced and complicated reactions to them. So again, we could spend a whole hour on any one of them. Rather than doing that, what I'm going to do is just give you one last example of an actual A/B test that caused controversy, which I think is pretty easy to kind of wrap our minds around. So Pearson is a, I think, global education publisher. And one of the products that they offer is educational software. So for example, to complete problem sets. And it's a problem, no pun intended, that students don't always complete all the problems that the professor would like them to. Sometimes they give up. And so Pearson came up with this idea, two ideas actually, to encourage students who weren't completing the full problem set to try harder to complete a few more problems. And so one idea, and these are all based in different sort of psychology theories, which I won't get into, one was to say, look, some students tried this question 26 times. Don't worry if it takes you a few tries to get it right. Another version, though, another option was to focus on mindset and say, look, no one's born a great programmer. Success takes hours and hours of practice. And so they randomized schools. So this randomization was at the cluster level. So you were not competing with people in the same class that you might be on a curve, a grade curve, or anything like that, who might have gotten a more efficacious nudge. No, different schools were shipped different versions of the software. And the third version was simply the status quo, which frankly didn't involve any encouragement. It was like, you're on your own. You know, you can finish the problem set or you can't. So that was the randomization. And if I had time, I would poll you to see what you thought that the result was. But I'm going to tell you, at least on one of the primary outcomes of how many problems did students actually complete, C, no encouragement won. And I think that's counterintuitive, and it's certainly not what a lot of experts would have predicted. So this was something that was not obvious, and we learned something from it. And they were presented that at a conference, and somehow the media got hold of it. And so the Washington Post reports the headline, "Pearson conducts experiment on thousands of college students without their knowledge." Sounds bad. Education Week reported on the fierce debate over issues of ethics, privacy, and consent, and reported that Pearson's stock actually fell noticeably after all of this. And here's a couple of, I admit, cherry-picked internet comments. "This would be funny if it were not also unethical and outrageous." Another person says, "A completely unethical and possibly illegal breach of scientific protocol by Nazi so-called researchers at Pearson." Okay, so quite a bit of pushback from that. I have written from a regulatory perspective and a little bit from a normative perspective on some of this, primarily on the Facebook and OkCupid experiments. But also in more of the recent publications, trying to tie this to the idea of the learning health system. Lots of people hate Facebook. I'm not here to defend Meta. However, the idea of being averse to experiments, at least some experiments, has the potential to threaten the learning health system. And that was frankly what was most concerning to me. And as I began to think about some of these examples, I observed what seemed to me to be a pattern. And so I imagined, what would have happened if Pearson had given all schools the A condition? The CEO had said, we can improve our product. We should just tell students that lots of people take 26 times. That has facial validity. It seems like it's well-intentioned. It seems like it might work, unlikely to do harm. Let's just give it to everybody. If they had given everybody option A, or if they had given everybody option B, or if they had done nothing and just stick with what they had done for years, where no one had complained, I don't think anyone would have uttered a peep. That's my hypothesis. I don't have the counterfactual. I can't observe, what didn't happen. But that was my suspicion, was that giving A to everybody and B to everybody was unobjectionable. But when you run an A/B test to compare those two things, the two unobjectionable policies inside the trial, some people get very upset. And it seemed like many of these examples might follow something like that broad pattern. And so my lab decided to try to empirically investigate that. Could we systematically observe this type of pattern of judgment and decision-making about A/B tests? And so these are the postdocs and pre-docs in the lab who have worked on this particular project over the years. In our earlier iterations of this in our earlier papers, we also collaborated with Duncan Watts, who was then at Microsoft Research and is now at Penn, and Will Kai was a pre-doc with Duncan at Microsoft and then went on to a PhD program at Stanford. Okay, so thanks to all of my collaborators. Thanks also to NIH for a bioethics supplement that supported some of this work and who I forgot to acknowledge on my slide. Sorry about that. Okay, so I'm going to start with the first paper from 2019. This was a series of 16 vignette experiments and replications. All but the first were pre-registered. Our samples were online US survey panelists who are diverse in all ways, but not perfectly statistically representative of the US, as well as some clinician samples. And in this first set of studies, we used what's called a between subjects design. That is, our participants were randomized to see one of 3 different vignettes only. And in all of them, a well-intentioned agent either decides to implement policy A, decides to implement policy B, or runs a randomized experiment comparing A and B, and then implements the best policy for everyone going forward. Our main dependent variable, or primary outcome, if you will, was how appropriate was the agent's decision. And we just used a simple 5-point scale with a neutral midpoint. We also asked them, so this is mixed methods, we also asked them to explain in a few sentences why they made the decision they did, and we had a very elaborate code book and qualitatively coded that. And then, of course, we collected demographics and other individual difference measures like scientific literacy to see if that predicted people's responses. Okay, like I said, 16 vignettes and replications. Obviously, I'm not going to go through 16. I'm going to go through 2. So the first is hospital safety checklist. These are the actual materials our participants saw. So those randomized to the A condition were told some medical treatments require a doctor to insert a plastic tube into a large vein. These treatments can save lives, but they can also lead to deadly infections. A hospital director wants to reduce these infections, so he decides to give each doctor who performs this procedure a new ID badge with a list of standard safety precautions for the procedure printed on the back. All patients having this procedure will then be treated by doctors with this list attached to their clothing. People randomized to the B condition saw the exact same thing, and key in experiments is to manipulate as little as possible, so we kept everything the same except this time, the hospital director decides to hang a poster with the same list of standard safety precautions for the procedure in all procedure rooms on the procedure room walls. So we have badge and we have poster. Same thing, same reminder. One is on the back of a badge, one is on a poster on a wall. Those randomized to the AB condition were told that he thinks of 2 different ways to do this, and so he decides to run an experiment by randomly assigning patients to one of 2 test conditions, half to ID badge, the other half to poster. After a year, the doctor will have all patients treated in whichever way turns out to have the highest survival rate. Okay, here are the results. So on the y-axis, I'm going to show the percentage of participants in each of the 3 conditions who either somewhat or who said it was either somewhat or very inappropriate. So badge, like 15% of people thought that the badge was in implementation was inappropriate, like 8% of people with poster. There's the A/B test, right? So many more people are objecting to the A/B test. Okay, why might we object to A/B tests of 2 unobjectionable treatments? Well, one possibility is that we have intuitions about whether A is better than B or B is better than A. We all have opinions, and we can call this subjective non-equipoise. So it's not that we're in equipoise in terms of the evidence base, but we may not be, in our own minds, we just have an intuition that poster is going to be better or whatever. Another possibility is that people have an aversion to people being treated differently. So some people are getting A, some people are B, that is different. And it might be unequal or inferior if it turns out that A or B are not equal, right? Also, people might be averse to random assignment. We like to think, especially, that our doctors are sort of artisanally brewing each treatment decision just for us. There's this sort of fascinating, we see this in so many of our free response comments, like, well, you're gonna look at everything about me in my medical record and you're gonna come up with the exact right hypertension drug just for me, et cetera. I'm mocking that a little bit just because I don't think precision medicine is really there yet. But, to be fair, like there are people who think, you're an expert, you're my doctor, I want you to make a decision about me. I don't want you to be flipping a coin. That's not how my treatment should be decided. It shouldn't be based on like an accident. All right. So to try to kind of control, quote unquote, for those factors, we came up with a different vignette where we infused those features. Those are features of the A/B test. They are. But we tried to infuse those features into the policy conditions that exist outside the trial. So this is a this is best drug walk-in clinic. So people who are randomized to the A condition are told several drugs have been approved by the US Food and Drug Administration as safe and effective for treating high blood pressure. Dr. Jones works in a multi-doctor walk-in clinic where patients see whichever doctor is available. Some doctors in the clinic prescribe drug A for high blood pressure, while others prescribe drug B. Both drugs are affordable and patients can tolerate their side effects. Dr. Jones wants to provide good treatment for his patients, so he decides that whenever his patients need blood pressure medication, they will be prescribed drug A. Those randomized to the B condition get literally the same thing, except Dr. Jones decides to join team drug B. Or in the AB condition, you guessed it, he thinks of two different ways to give good treatment, et cetera, et cetera. He runs an experiment, half to drug A, half to drug B. After a year, he'll prescribe whichever one has the best outcomes. So notice that in this vignette, there's no way to really intuit that drug A is better than drug B because we've made them totally generic. We've taken away any way for someone to say, well, poster is just going to work better. It's literally drug A and drug B, right? So we've kind of removed the subjective equipoise thing. Importantly, outside of the trial, people are being sort of in the regular world, in the standard of care version, in the A and the B conditions, people are being treated randomly, quote unquote, in the sense that the treatment they get, A or B, is a matter of unwarranted variation in medical practice, right? It is an accident of when they walk in the clinic and who happens to be there. So there's a randomness to that, the way we've set up the vignette. And it's also the case that this population, the clinic population in aggregate, is already being treated differently and potentially unequally in that some are getting A and some are getting B. So those features are true across all three conditions. All right, here are the results. Same thing. Y-axis is the percentage of participants in each condition who said that the decision to do this was somewhat or very inappropriate. Not surprisingly, drug A and drug B are basically indistinguishable. You remember poster and badge, people had a little bit different views. Nope, indistinguishable. There's the A/B test, right? Okay, so same sort of pattern. We replicated both of these experiments with clinician samples, and we saw the same pattern of results, pretty large effect sizes. Okay. Incidentally, we looked at doctors versus nurses, and we also looked at all prescribing providers versus nurses, and we did not see any differences there. Okay, in this first paper, we did look at several other domains adjacent to or totally outside of health, direct-to-consumer genetic testing, return of results. Do you return everything or just the actionable stuff? Global health assistant recruitment, two different ways of recruiting those folks, autonomous vehicle safety, and we found this A/B effect, as we called it in this first paper, in all of those 6 cases. We did not find it in a 7th vignette that looked at 2 different ways of implementing universal basic income. Okay, back to the why question. Well, it could be science literacy, right? It could be that people who are more scientifically literate are less averse to scientific experiments, right? Well, we already have the results of the healthcare sample. So as a whole, they exhibited some of the same results, and there was no difference between doctors and nurses, for example. We also collected whether participants had STEM degrees or not. That didn't make a difference. We gave them an NSF literacy scale. That didn't make a difference. What about other demographic variables? We looked at education, sex, race, ethnicity, age, political ideology and party, and religiosity. None of these variables predicted more than 1% of the variance in response among our participants. Now to the free response comments. This is not all of the results. These are just a few hints. So importantly, our vignettes, you may or may not have noticed, are silent about whether consent is happening or not. But I think a lot of people assumed that it wasn't, and I think that's a fair assumption to make. And many of the people in the AB conditions in down rating, I will say the AB decision, AB test, mentioned the seeming lack of consent as a problem. What I find interesting about this is that when you look at the people who mentioned the lack of consent in the policy conditions, it's like 0.3%, it's like 2 people. And what I find interesting about that is that the same risks and benefits that the A and the B test in aggregate contain are imposed, that they impose through the trial are in aggregate imposed on the population through giving everyone A or giving everyone B. And yet no one thinks that consent is even a reasonable thing to ask a hospital to do for that. Of course, you can just hang a poster. Why would you ask patients permission for that? We also see what I would call aversion to experiments per se. So in 24% of people who explain downrating of the AB condition, they say something like, you just can't experiment on people. So the word experiment is sort of talismanic. Interesting again that you only see that in like 0.1% of policy conditions. Why is that interesting? This argument is not novel to me, others have made it, but the A is just an uncontrolled experiment. Giving everyone A is an experiment that we can't learn anything from. And same thing with giving everybody B. It is an experiment to hang posters on the wall without having tested that in any way, not knowing what's going to happen. Okay, finally, we observed what we call a proxy version of the illusion of knowledge. The illusion of knowledge is sort of overstating what you think you understand about how something works. And a proxy version of that is when our participants say, no, someone knows the answer here. Someone knows the answer. You just need to implement that. I don't know whether it's the FDA or the CEO or someone in JAMA. I don't know, but someone knows the answer and you just need to know that. So there was quite a bit of that. Okay. After that first paper, we shifted to a within subject study design. This means that all of our participants see all three options, the A, the B, and the A/B test. And so these are true of these next two papers, as well as the the work in progress that I'm going to show you and sort of conclude with. And what this allows us to do is a few things. So first of all, we know from behavioral science that when people evaluate something jointly, something compared to something else, that can affect how they evaluate each of the two items versus when they are evaluating it in isolation. So in the between subjects studies, the people evaluating the A/B test are only seeing that. So for example, they're not seeing that counterfactually, the alternative is for him to just give everybody A or everybody B. Maybe that would make them accept the A/B test more, like, oh, it's in his power to just do both of these things, so actually why not give half and learn and etc. Conversely, people looking at just poster might think, oh yeah, it sounds good to me. But if they knew that badge was also an option, then they might start weighing the pros and cons of each and might think, oh, well, what else is out there? What other options, et cetera. So joint evaluation rather than separate could be the result that they like the A/B test more and dislike the policies more. And that could make the difference between them go down or go away. It also allows us to have stricter definitions of what we mean by experiment aversion and also experiment appreciation, which I'll go over on the next slide because it'll be easier. And finally, because they're seeing all three things, we can actually just say, which should he do? What's the best thing he should do? What's the worst thing? Just rank those three. All right, so we redid hospital safety checklist. We've done many other vignettes too, but you're sensing a theme. I'm continuing with the theme of just these two vignettes. And so you can see the same pattern of results. And this is with people who are looking at all three options, right? So you're still seeing basically the same pattern of results. Now what we can do, because everyone has rated all three things, we can plot. On the left is the average rating of badge and then the average rating of poster. But what we can do, some people think poster is better and some people think badge. So we can take every individual participant's favorite policy and we can come up with the mean of that. And that's what you see with highest rated. And conversely, lowest rated is everybody's least favorite policy, which for some people is badge and for other people is poster. And we're going to define experiment appreciation as rating the A/B test as better, statistically significantly better than the highest policy on average that the population thinks. And we're going to rate, conversely, experiment aversion as rating the A/B test lower than. So you're looking for ratings that are outside of that gray zone. And here's what we see. We see the A/B test is in fact outside of the gray zone. We see experiment aversion. And then when we ask them to rank, we see that 48% say that the A/B test is the worst thing that he can do. Okay, real quick, here's best drug. Again, same pattern of results in within subjects design. Here, everything is flat, right? Because no one can distinguish between drug A and drug B, so everything is flat. And here again, we see the A/B test experiment aversion, and we have 45% saying it's the worst thing that they can do. Okay, I mentioned the vignettes up to this point have all been silent about consent. They've also, incidentally, said nothing about ethics oversight. They've said nothing about notice. These are three, I'm going to call them ethics policies, that could be helpful in mitigating or maybe eliminating experiment aversion. Now, I will say one thing about consent. Again, happy to talk about this later. It is not always possible, either feasibly or scientifically possible. Ultimately, you have to do this pragmatically. You can't always get consent. Still, it's important to know to what extent the absence of consent is driving experiment aversion. And the other two policies, oversight and notice, are absolutely things that we can do and give people. And so it's equally important to know what they think about that. All right, so in this case, it's the same within subjects design where they see A, B in the A/B test, but within the A/B condition, people are randomized to see one of 8 different versions of the test. And it's just the permutation. It's just eight cells because it's just the permutation of whether consent exists or does not exist, oversight exists or does not exist, et cetera, each of those things independently. And so just as an example, in the version where there's oversight and notice and consent, after describing the A/B test, there's this new paragraph where we say an ethics board has reviewed this experiment to ensure that it adequately protects the rights and well-being of patients. Patients who get treatment at the clinic, sorry, I've got things that are blurring my view, are notified through brochures and signs of the clinic's general practice of running experiments like this. Patients are asked for their consent to the experiment before they are randomly assigned to one of the two conditions. In the no condition, as we call it in the lab, no oversight, no notice, no consent, it's a little harsh. You know, we said there is no ethics board that has reviewed this. Patients are not notified and patients are not asked for their consent. Those words are not in red in the materials. They're in normal. I'm showing that to you to show, again, we are being very sparse in what we manipulate, as little as possible. Otherwise, the wording is exactly the same across conditions. Okay. Hospital safety checklist, one more time with feeling. So here on the left, again, are the familiar ratings. And here are the 8 tests of the A/B test, the 8 different ratings of 8 different A/B tests. The grayed out means no, means they were told there was no oversight, there was no notice, there was no consent. Not surprisingly, that one did the worst, right? Very significantly below the neutral midpoint. Population on average objects to this. Okay. And in fact, 73% said this is the worst thing that you could, this is the worst decision of the 3, right? Leaping over to the top, here we've given them oversight, notice, and everyone involved has consented, and we still see experiment aversion. And 42% of people still say this is the worst of the 3 options. It's worth looking at oversight only because I think this is where we are today in learning health systems. There's some oversight with a caveat that some of these things are run under non-research determinations where there may not be a QI/IRB. So we can have a conversation about oversight, but it's the closest to the status quo. And, you know, it's in between, right? And you still have 60% saying this is the worst option. It's also worth looking at oversight and notice because that's where we could be. I think there is very little, if any, actual notice or transparency in learning health systems about these things, in particular about randomization. But we could do it, and it helps a little bit, but not that much. Okay, here's best drug walk-in. Here, we actually did this one before the last one I just showed you, and for reasons lost to memory, we coupled oversight and notice together. So you either saw an A/B test that had oversight and notice, or it had neither oversight nor notice. And so instead of 8 permutations, we have 4. And so here are the 4 A/B tests. Again, the thing with nothing is worst, and like a strong majority think it's the worst thing to do. Here, hurrah, it's in the gray zone. For the first time, we do not observe experiment aversion. Notice though, we have to give people oversight and notice and consent. And this is an unwarranted variation in medical practice scenario where people are already being treated differently and possibly unequally outside of the trial without any consent, et cetera, et cetera, et cetera. So we've layered on a lot of things here in a way. And it's just barely in the gray zone. So we do not observe experiment appreciation. No one is saying, and this is ideally what the Institute of Medicine wants. One of the pillars of the learning health system is supposed to be an engaged patient community. It's not supposed to be something that leadership is just doing or researchers are doing on their own. And we don't see in these lay samples appreciation. And we see 22% still think it's the worst thing. Again, everyone involved is consenting. It's still the worst thing to do. Okay. Why do people object to A/B tests? We can now look at the people who are randomized to the yes, yes, yes version of both of these vignettes. That is the version where there was consent and oversight and notice, who then objected to the A/B test or experienced or exhibited individual experiment aversion. And we can look at their free response comment and say, okay, what's going on? So this isn't a complete, comprehensive set of qualitative results. It's just some hints at a few themes. Again, we see some objection to experimentation per se. Oh, and let me also, all of the participants that I'm showing you quotes from passed 100% comprehension and attention checks, where they accurately recalled later in the survey, yep, you showed me an A/B test that had consent and it had oversight and it had notice. So they knew what they were talking about. All right, the A/B test is, oh, and I should say in the brackets, we called in the materials the three things, situation 1, 2, and 3. So I'm just replacing situation 2 or whatever, and they were shown in randomized order. Just replacing that with what the thing was that they were talking about. So the A/B test is worse because he should not be experimenting with their health. Drugs A and B are equally good and better than the A/B test. So implementing one versus the other isn't experimenting with their health, but doing an A/B test is. You shouldn't experiment because it's an experiment. Already a hint of this theme in the last comment. Very interesting the way people people's risk perception. So there are lots of quotes that sort of attribute all the risk to the A/B test, but none of it to either policy implementation. I chose poster as the best way to solve this because doctors can easily see the list of precautions without having to actively move a piece of clothing to see them. Fair. Badge is also good, but less convenient than one. The A/B test is not ethical. Life-threatening experiments should not be performed on humans. But the thing is, if you are catheterized, there is a risk of infection that can sometimes lead to death, and that's the case in all of these policies. It's not clear why the A/B test should be a life-threatening scenario when the A version or the B version isn't, or for that matter, the status quo where there's neither a poster or a badge. Some of our comments specifically call out the pragmatic nature, or rather the healthcare setting of these trials. I don't support conducting experiments on patients who just need and want quality medical care. While indeed we do, and of course the problem is, it's really hard to figure out what that entails without doing some of this work. And finally, the illusion of knowledge. I don't like the idea of doing an experiment on people. Everyone should get the best medication right from the start. Indeed, we should. Hard agree. Unfortunately, alas, we don't have that information, right? And to some extent, pragmatic trials are how we get that information. Okay, some conclusions so far. We can observe experiment aversion in several domains, in health, in public health, and in other domains. We do not claim that people are always averse to experiments or to every experiment, only that we can observe it. It persists after controlling for inequality and randomization, such as in the best drug walk-in scenario. It persists when participants are exposed to all three options and see counterfactuals. Educational attainment, science literacy, and demographic variables explain essentially none of the variance among participants. The proxy illusion of knowledge is one mechanism of experiment aversion and may explain why RCTs in novel areas where knowledge of what works is necessarily lacking. Everyone agrees that no one knows how to cure COVID in the middle of COVID, are more acceptable. We did a bunch of experiments about COVID. Happy to talk about that in Q&A. Of course, more research is needed. Causal mechanisms, we have some hint, but we haven't cracked the nut. Boundary conditions, how trivial can the A/B test be before people stop caring at all? And importantly, debiasing interventions. What kind of, is it education? What kind of interventions are needed so that the patient community and frankly, the clinician community is aligned with those who have embraced the learning health system model. In my view, we already do too few A/B tests. We already allow unwarranted variation to persist, and we already allow people with VP at the front of their title to implement all kinds of policies and practices just because they have those initials at the beginning of their title without ever testing them for a lot of reasons. And so experiment aversion may be one more obstacle layered on top of that. Again, we never observe mean, or that is population level experiment appreciation, and that's really in tension, as I said, with the aspiration of a learning health system. Finally, health systems that do A/B test, I think I and probably all of the ethicists on that slide I showed you earlier about defending non-consensual A/B tests would acknowledge that we should be transparent about that. Even if we're not asking your permission, we should be transparent about it. But telling people that we're doing A/B tests requires explaining why we're doing them. And a big part of the answer to why we're doing them goes back to the very first slide. Doctors don't know what they're doing. I invite you to call up your marketing department and have a conversation with them about how it would go to have a patient town hall meeting and say, like, we don't know what we're doing, so we need to A/B test all of these things. All right. Finally, I would be remiss not to acknowledge the influence on this line of research from Ruth Faden and Nancy Cass and Tom Beecham and others, but in particular, I'd like to call out Tom's work on the research practice distinction. Here's one quote from his acceptance speech way back in 2010 that I like. And as all of you know, this is the philosopher behind the Belmont report, right? And he said, but research makes it possible to avoid the harm that may result from the application of previously accepted routine practices that on closer investigation turn out to be dangerous. And I would add to that, not just existing practices, but as I said, new practices that leadership is empowered to just impose on everybody because they're leaders. When I think about this line of work, and how I am often at odds with most of my colleagues in the ethics community. I can see lots of uncomfortable twitching in seats, and I look forward to the conversation afterwards. I often am reminded of Rubens' vase, where depending on your perspective, you either see a vase in the foreground or you see two faces in profile gazing at each other in the background, right? And I like to think of, research in the foreground. That's what happens if you're a research ethicist and that's how you're trained. The vase of research is in the foreground. It's also in the foreground for the public. When the New York Times splashes, things about a non-consensual experimentation. What I think is too often forgotten is the background of practice, whether that's medical practice, public health practice, industry practice, whatever it is. And so, I think that not only is it not always unethical to conduct an A/B test, even without consent, some of those tests are ethically laudable, and I would argue that some are ethically obligatory. And so I will conclude with as stark a claim as I began, which is to say that sometimes it's unethical not to run an A/B test, even one without consent. And I think that's an interesting line of research to explore and develop. Thank you very much.
Well, Michelle, thank you so much. Clearly, you identified a lot of maybe discomfort and frustration for those of us who do some of this work. I'm already seeing Mary Catherine, so I will not.
Hi, that was excellent. I loved that. So what it makes me think of, which is you alluded to in sort of one of the future areas of research, as I was watching it and I was absorbing what was happening, I was thinking, okay, how do you enhance research appreciation or experiment appreciation? And so how could you prime people at the beginning of a survey? And if you prime people, can you develop a way of priming people so that, you move people up into the experiment appreciation area? And maybe that requires testing different versions of how to prime people. And you do the marketing team a big favor, because when we develop our notification strategies, we could rely on experiments that tell us how to do it most effectively.
Absolutely. Thanks for the question. 1000% agree. Yes, first of all, this is totally meta. I'm doing vignette experiments about experiment aversion. Totally agree. This is just more experiments we just haven't done yet. And, we should A/B test front door notices, for example. A lot of questions, a lot of choices to be made, and how you frame that. What does that notice look like that says, hey, probably not the Christian rudder. We experiment on humans, probably not the best approach. But there's a lot of work to be done on that. And we are working on it. Yeah.
So maybe following up on that, then, if you're in this at least liminal space where you're not yet at the stage where you know how to prime people and there's full buy-in, but you have a health system that's committed to actually doing this A/B testing, what do you do? Because you've identified, you think there's this commitment to transparency, but it seems like there's this risk that by telling people, you might scare them away from your health system, make them distrust you. How do you navigate that? Are there some types of A/B tests for which it's more important to tell people, and others this is just our health system. We would get to do this anyway. We don't have to tell you.
So since this is merely going to be posted on YouTube for the whole world to see, I will say I like kind of low key live in fear because I wear several different hats, and one is doing this lab research, and I am really passionate about evidence-based practice in the health space and outside of the space. And partly for that reason, as I kind of alluded to earlier, I co-launched this unit at Geisinger that does these pragmatic trials, many of them around uptake of vaccination, but not anymore. And yes, it is a liminal space. It is a very uncomfortable space. I am not uncomfortable at all with what we're doing, but I also suspect that most patients, and this isn't limited to just randomization, like I think most patients have no idea how much health systems use their data. For example, just data studies. Like I just don't think their expectations and reality, I think there's a huge gulf. And I have seen, not related to experiments, but I have seen other occasions where, you know, one patient complaint shuts something down. And so, yeah, yes, you know, the right thing to do is to be transparent, but also the right thing to do are to do these trials. And yes, and so a lot of it comes down to culture and will there be a defense of this work? And yes, take the call with the patient, walk them through it, explain why we're doing it. Yeah.
Thank you so much. This was fantastic. Hi, I'm Julie Bollinger. Done a lot of work with Jeremy Sugarman on pragmatic clinical trials, and this all, first of all, resonates very highly from what we did. And when your point about people are unaware about how much their data goes, we were doing a project on where people get a collateral finding out of some of these pragmatic trials and asking people what should we do? Should we let the people know who didn't even know they were in the trial? So of course, the first pushback was, what? You know, like, why didn't we, you know, and so with the first 10 minutes of a focus group would be like, this is what's allowed to be done, this is where you go, no insurance claims, the whole thing. You could sort of push that aside and then said, this is the way things are. And then we would have a little, like one of our primers was, there's all this data that's being held that we can learn from, you know, we try to do like stuff like it's already being collected. We have all these health records. Hospital systems think, you know, we can ask good questions of the data to find out things. And what you're seeing is people do not like uncertainty about their doctor. They have this myth that their doctor knows everything about them. They might be going to a walk-in clinic for care, but there's this great myth that there's this, they know them better. Uncertainty. Did you add any health anxiety skills?
No, it's interesting.
Some people are more like, that's part of doing business. Others are like,
Yeah, that's interesting. Yeah, thank you. Yeah, you know, I think we just have to at some point kind of dive in and bite the bullet and start telling people. I will share a story from another institution. I don't think it's a secret, but I won't name the institution anyway. And they did some of these trials and they decided laudably, like, let's share the results with our patients. And it was, I think it was something like, I don't know, surgical tape or some other type of like whatever. And someone in the audience, you know, raised their hand and then they said, so, you know, we figured it out. This one's better than this one that we had been using as standard practice. And someone in the audience said, you mean you've been doing it wrong for 100 years? And there was like this silence fell across the room. That's one way of looking at it. And so they're like, okay, we're going to workshop the next version of this. I mean, but yes, that is one way of looking at it. So, yeah.
That was brilliant and so precise and clear. Thank you so much. I have a question to make sure I'm understanding something. So there was one, I think maybe the last experiment that you showed, I think it showed that, or your slide showed that 22% of people thought the AB was the worst.
Yeah.
There. So I'm curious about that. What did they rank A and B?
Yeah, so I mean, a lot of people complain that like, well, you didn't let me tie drug A and drug B. So some like, I did it in alphabetical order or I just randomly like whatever. Yeah. But they were like, I don't do A or do B, just don't do the AB test, or that's your third option. Yeah. I think I remember one comment that said, well, drug A came out first. So I thought, or no, I think they like drug B came out later, so it might be better. So I like put that first. Misunderstanding. There was like one comment about that, but most people just said like, I can't tell that, I don't have any reason to distinguish between A and B. So I just made them 1 and 2 in whatever order. But nevertheless, they're like, but the A/B test is worse. Yeah.
Me again. It's Mary Catherine Beach. So, when you just mentioned again, this idea that the survey respondents think that their doctor is going to pick what's best for them, particularly. One thing that does occur to me is it may be that you don't think that that you think that you could have A and B described to you, and then like you would pick with your doctor which one. So I wonder whether there's a way of incorporating that in, because it's not so much that I think like my doctor's going to pick the most one. What I don't want to necessarily give up is the choice to like understand this one has that trade-off versus this trade-off, et cetera. So like every drug is different. So maybe is some rationality to the not wanting to lose the choice.
I think that's fair. I think that's fair for the comparative effectiveness drug trials to some extent. I don't think it reflects reality. I am on 2 hypertension agents and my doctor was like, yeah, start taking it. Bye. I mean, there's no conversation. There's no shared decision making. It's just not reality in 2025, at least not with my physicians. But it's a fair aspiration to want. I think it's a little bit less fair when you talk about something like checklist, right? Where it's a policy practice. Like, are you hanging this? Are you hanging that? There's no shared decision making about, how you're reminding your providers. Like, that's not a thing. Yeah, but we also get a lot of why not do both? So especially in check and poster and checklist, right? People are like, it can't be that expensive. Like, stop being so cheap and just give badges and posters, right? Also fair, although again, like we do live in a world of finite resources, and sure, maybe hanging posters or badges aren't that expensive, but every little bit counts. Still worth trialing it. I'm sure we could come up with some A/B test where it was not inexpensive to do both. And of course, you probably shouldn't do both in the hypertension medication. You shouldn't just be like, let's just give everybody all the drugs, since we don't know which is better than the other. Right. Yep.
I'm Kayla Meal. I'm a postdoc fellow here.
Hi.
And I was just thinking that I wonder if there is a way for people in this space, scholars in this space, to kind of, because it just sounds like there's a lot of things that the general public don't know. They're not aware of how much their data is being used. They aren't aware of how little their doctors know. They don't understand the value of pragmatic trials. And so I didn't know if there was like should we be like doing public facing work to like clarify this kind of information? It sounds like talking to the patients in the hospital that's doing a pragmatic trial or is part of a learning health system freaks them out. But like talking more generally about the value of pragmatic clinical trials and like clarifying this stuff that's so uncertain to the general public would be helpful in some way without freaking them out. Like, I don't know. I'm just trying to think of a way to address this problem.
Absolutely. I think, the answer has to take the form of something having to do with education and communication, for sure. Probably, people are busy and they don't care about some of these nerdy things. And so you have like limited opportunities to actually get their attention. So I think the front door notices, pamphlets, we have like Geisinger TV, I'm sure you do at Hopkins too, like in hallways, whatever, you can run these ads. There are opportunities where people are kind of paying attention if they're not on their phone, where you can start to kind of communicate and socialize some of these ideas. And then we're going to need the A/B testing of all of that to see Because it's complicated to explain too. I mean, pragmatic trial, there's a lot of concepts in there stacked on top of each other. Randomization, why is that important? Why can't you just do pre-post? That's a whole thing, right? The pragmatic nature of it. Why can't you do it in some like research hospital over there? Why do you have to do it here? All of those concepts are complex and all of them deserve their own little series of A/B tests. Like what is the best way to communicate that? It's the same thing with science communication, right? There are complicated concepts and there are better and worse ways to communicate them. And those are all empirically testable and they should be empirically tested. So yes to all of that, you know, and sure, if the K through 12 curriculum people also want to make space for this stuff, I am here for it. They could also add statistics and just A/B testing in general, I would love. I'm not holding my breath for that. You know, I think in terms of like, when people say like, oh, we should have, I like, what is the public communications, like town hall, like who's gonna come, right? They're living their lives, right? They're doing other things. So I think it's hard to find an opportunity where you can really capture their attention and start to have like a conversation or even, yeah, a unilateral disclosure.
That brings us to time. I know many of us have many more questions we can ask you. We'll look forward to other opportunities, but Michelle, thank you so much for joining us for this.
Thank you for having me.